Okay, it looks like Melissa started it. So I've just started the recording of this open meeting in compliance with CMS guidelines. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting. Palmetto GBA only recognizes the Teams webinar recording that will be posted on the Palmetto GBA website as the accurate and reliable record of this meeting. Before we get started with our speakers, I just want to make a couple comments, quick comments about this LCD that's up for reconsideration on botulinum toxin injections. First, let me just make some general comments that the LCD is intended for indications and limitations for botulinum toxin dosing must be used in accordance with the US FDA approved labeling. The LCD addresses off-label use, and evidence is reviewed and coverage decisions outlined in the LCD itself. Changes to the LCD, however, must be supported by robust clinical evidence. For off-label botulinum toxin use not addressed, the provider must provide robust published clinical evidence to support the dosing of a specific of the dosing or of a serotype use that is indicated. For new FDA-approved indications for botulinum toxin serotype or dosing recommendations after the effective date of the policy, the qualified healthcare professional must provide the updated published FDA prescribing information to support the use of botulinum toxin serotype or dose. Furthermore, botulinum toxin administration must not be given more frequently than every 12 weeks, regardless of the diagnosis, unless specifically addressed in the LCD policy itself. The use of botulinum toxin for all cosmetic procedures is not a covered benefit under Medicare and is statutorily excluded. When botulinum toxin is used for an approved diagnosis, but the botulinum is also being used for cosmetic intent, the entire claim will not be considered reasonable and necessary. The potency of each botulinum toxin serotypes are not interchangeable with other botulinum toxin serotypes, and therefore, if one is FDA approved, does not necessarily confer that another serotype is to be used. With those general guidelines specified in the LCD and the accompanying LC article, I'd like to now go ahead and turn it over to our speakers for a presentation this morning.
Good morning. I'm Andrew Eiseman. I'm an ophthalmic, plastic, and reconstructive surgeon with over 30 years of experience. I'm currently the chairman of the Storm Eye Institute at the Medical University of South Carolina. But I do have to qualify my comments that these do not represent the Storm Eye Institute, the Medical University of South Carolina, or the state of South Carolina. However, I am representing the American Academy of Ophthalmology, the North American Neuro-Ophthalmology Society, and the American Society of Ophthalmic, Plastic, and Reconstructive Surgery. I really thank you for allowing me to discuss these proposed changes. I think as we would all know, these facial dystonias and ocular dystonias can be extremely devastating for patients, preventing them from reading, driving, working, and feeling comfortable in social situations. And the use of botulinum toxin has truly revolutionized the treatment of these disorders, allowing patients to become independent again. And these are some of my most grateful patients. And so my comments are all based on ways to continue to help improve the lives of these patients. I'd like to start my comments by indicating that we highly recommend revising number 16 in the general notes of the LCD from Medicare will allow payment for one injection per site, regardless of the number of injections made into the site. A site is defined as one area, to an applicable CPT code is reported once per eye or side of face without regard to how many injections are performed. I think it's widely understood that the code is reported once for a series of injections. In terms of blepharospasm dosing and inconsistencies within the LCD, I feel that the initial dosing of 1.25 to 2.5 units per 3 injection sites for onabotulinum toxin A, from here forward described as Botox, is clinically insufficient in dose and number of injections. Typical retreatments require 5 to 9 injections with a dose closer to 25 units to effectively manage symptoms. And once again, this is based on over 30 years of personal experience. This total dose of 25 units is consistent with the initial dosing guidelines for incobotulinum toxin A, from here forward known as Eiseman, which has a similar efficacy and safety profile as Botox for this indication. The initial dosing regimen for Botox should be revised so that both Botox and Xeomin be allowed for as many injection sites as necessary, up to 25 units per eye. In terms of Mage syndrome and blepharospasm with orofacial dystonia, as noted in the LCD, more than 50% of blepharospasm patients will eventually progress to Mage syndrome. This progression requires increasing doses as more facial muscles need to be injected for symptom relief. The LCD should be revised so that Botox is allowed up to 50 units per eye, aligning with Xeomin in those dosing guidelines. In terms of blepharospasm with orofacial dystonia, there is no clinical rationale to exclude Xeomin from the coverage. Botox and Xeomin are interchangeable in practice for this condition. And in fact, oftentimes when pharmaceutical representatives present at our clinical office spaces, one of their key discussion points is that the efficacy is equal to that of Botox in these situations. For hemifacial spasm and for strabismus, in terms of hemifacial spasm, there's really no clinical justification for waiting 1 year, which typically would be another 2 or 3 treatment sessions to increase the dose and or the sites of injections for patient relief. Increased dosing should be based on the clinical response and should be performed at the discretion of the physician at the next treatment session based on an inadequate response to the prior treatment dose. For strabismus, the initial dosing of Botox of 1.25 to 2.5 units in any one muscle is appropriate, but only for comitant strabismus. For paralytic and large angle strabismus, doses up to 10 units are often required. And in fact, the drug vial size and waste are unchanged, resulting in really no cost increase to Medicare for these situations. Really problematic is the fact that there are no provisions for patients who have been receiving higher doses than are now described in the LCD. And some of these patients have been receiving these higher doses for months, if not years, not allowing us to continue to provide these patients with the doses that have been working with them for an extended period of time, risk significant care disruption of care for these patients, which could once again cause a great disability. The potential denial or restriction of medically necessary treatment is a real problem, with there being no grandfather clause or the ability to allow these patients to be treated with the doses that have been working for them. We also strongly believe that the use of a clinical scale is unnecessary and burdensome. It takes much longer to go through one of these clinical scales as opposed to simply determining that there is enough cause for treatment initially, that after the treatment that the symptoms are significantly improved, and that before the next treatment is given that the symptoms are coming back. Reporting quality of life, therefore, from prior injections, the narrative element in the note to establish medical necessity is, in our opinion, much more appropriate. In summary, the AAO, ASOPers, and NANOS encourage policy revisions to support physicians' discretion and patients' access to medically necessary care that can be absolutely life-altering for these patients in a positive way. We strongly recommend reconsidering the restrictive dosing limits and escalation timelines. We also feel like this policy should align much more with the real-world ophthalmic practice, which many of us have been performing for decades. We also highly request and recommend reducing the administrative burden and barriers while preserving safe and effective care. I'd be happy to answer any questions if there are any. Yeah, I thank you for your time, and I would love to reiterate how important potentially changing these policies would be to really helping these patients, which is the whole motivation for the discussion today. Thank you.
Don't believe, Melissa, I don't believe we have any other presentations. Is that correct?
That's correct.
All right, well then, thank you everybody for attending. And with that, we'll conclude our open meeting at this time. Thank you very much, everybody.